from all over Maharashtra. Maharashtra IAP President Ram Gopal sir, all IAP members and our special guest Dr. Narmada Ashok, who is an important person in CIP, who is very active for environmental and allergy chapter. Today, we will be discussing very timely but serious topics which needs immediate intervention from all of us. Now, may I invite Raigad IAP editor and EB member, Dr. Neha Singh, for formal welcome as well as introduction of our speakers and experts. Over to Dr. Neha.
Thank you, Chitra ma'am. Good evening, everyone. Myself, Dr. Neha Singh, and on behalf of Maharashtra IAP as well as Raigad IAP, welcome all the respected dignitaries, seniors, and colleagues for today's journal journey. I welcome MahaIAP President Dr. Ram Gopal Chedara sir, Secretary General Dr. Amol Pawar sir, Coordinator Dr. Satish Sahane sir, as well as all the respected executive board members of Central IAP and MahaIAP. I also welcome Raigad IAP President Dr. Vikas More, Secretary Ajay Kohli, our patron and very own respected Dr. Neeman Mohanty sir, Dr. Chitra Kulkarni ma'am, Dr. Narmada, as well as all from Raigad IAP as well as other branches. Today, we are very fortunate to have with us extremely passionate and learned Dr. Ramakant Patil sir as our MMC observer. Sir was immediate past president of MahaIAP as well as at present executive board member of Central IAP from Maharashtra. Attendees, please note today's session has been granted 1 MMC points. So please requesting everyone to please type your name, MMC number, Central IAP number, city in the chat box. So friends, for today's session, we have two experts with us, Dr. Pradanya Joshi, MD Pediatrics, DPAA, Assistant Professor and in charge, Allergy Asthma Clinic at MGM Medical College and Hospital, Aurangabad. Our second expert is Dr. Lalit Yune, MD Pediatrics from GMC Aurangabad. At present, sir is Professor and HOD Pediatrics at Indian Institute of Medical Science and Research, Jalna. Since 12 years, he is immediate past president of IIP Aurangabad, Deputy Coordinator MEU, ACME 2020, also national faculty from IIP. Sir has 22 publications in index journals. While our presenters for today are Dr. Prachi Goel, resident in Department of Pediatrics, MGM Medical College and Hospital, Aurangabad. She will be presenting the paper Adverse Environmental Exposure and Respiratory Health in Children. While our second presenter is Dr. Simira Sheikh. She is also a junior resident at IIM SR Jalna. She will be presenting the research article of systemic approach to evaluate sudden unexpected death in children. So first I request Dr. Prachi Goel to please share your slides and you can start your presentation. Over to you.
Thank you, ma'am. I'm sharing my screen. Good evening, everyone. I'm presenting a journal club on adverse environmental exposure and respiratory health in children. My moderator is Dr. Pradnya Joshi, ma'am, Assistant Professor in Department of Pediatrics, MGM, Aurangabad. This article covers major air pollutants, types of environmental exposures, their exposure pathways and adverse health consequences, air quality standards, impact of climate change on children's respiratory health. Climate change has a profound impact on children's respiratory health, from rising temperature and air pollutants to the proliferation of air allergens and the frequency of wildfires. The consequences are far-reaching. Pollution has killed more people in 2016 than AIDS, tuberculosis, and malaria combined. Children are more susceptible to pollution. This is due to their different physiology. Relative to their body weight, children breathe more air, they drink more water, they eat more food than adults do. They also have a higher surface area to body weight ratio than adults. They receive higher doses of toxicants in any polluted environment, and young children are less likely to be able to detoxify xenobiotics. Most air pollutants are composed of incomplete combustion, that is, a mixture of particulate matter and gases. Particulate matters are carbonaceous core with various chemicals, metals, or other toxicants adsorbed to their surfaces. They are classified by their size by measuring the mass median aerodynamic diameter. Based on these, the particulate matters are either coarse particles, which have MMAD more than 10 mm, which do not generally reach the lungs because they are filtered out through the nose and the upper airway. Next, we have particulate matter 10, PM10, which have an MMAD of less than 10 mm. These are the mainstream of most air quality indexes. Then we have respiratory particles which reach the lungs, which have the size of MMAD 5 mm to 8 mm. We also have PM 2.5, PM1, PM 0.1, which are ultrafine particles and nanoparticles. The gases includes carbon monoxide, nitric oxide, sulfur dioxide, and volatile organic compounds. Volatile organic compounds are like benzene, toluene, and metal traces. Ozone is a secondary pollutant formed as a photoreaction between nitric oxide and volatile organic compounds in the presence of sunlight. These gases have an impact on the mucous membrane in the eyes and nose and may penetrate deeper into the airway tree. The mechanism involved in the adverse health effect is an oxidative stress. This is a term used for oxidant stimuli overwhelm the antioxidant defenses and cause tissue damage and inflammation. There is also another term known as environmental persistent free radicals. These are relatively recent described combustion products which persist for a longer time in the environment and affect the biological systems. These are the different exposure pathways. It can be the non-nutritive ingestion, inhalation, transplacental, transdermal, or breastfeeding. The different environmental exposures are of four types: household air pollution, indoor air pollution, exposure to air pollution outside the home, and impact of climate change on children's respiratory health. Household air pollution. The sources are unclean solid and biomass fuels for cooking, lighting, and heating. 4 million excess deaths per annum are from the non communicable diseases caused indirectly due to household air pollution. 50% of the pneumonia deaths in children under 5 years of age are also attributed to household air pollution. The primary exposure pathway is inhalation during the cooking procedure. Soot and other combustion products, they contaminate the stored food within the houses. Burning biomass releases a variety of gases and particulate matters. Adverse health consequences are vast. They affect developing fetus, the respiratory system, cardiovascular system, and brain. Anemia during pregnancy and childhood is more common and more severe in those exposed to biomass emissions. Infants and young children are likely to be exposed more along with their mother because, especially during the cooking meals. Female children are likely to be exposed more compared to males because they spend more time inside the house for household duties compared to their male counterparts. The adverse respiratory health consequences from household air pollution are due to different mechanisms and they have different health consequences. For example, in the fetal development, maternal inflammation, oxidative stress, epigenetic changes, direct particulate damage. They affect the poor placental function, they reduce the lung growth, and they delay immune maturation, which results in low birth weight, IUGR babies, low lung function at birth, increased infection, increased risk of pneumonias, and lifelong increased risk of COPD or lung cancers. Similarly, in infancy and childhood, through direct particulate damage, systemic inflammation, oxidative stress, DNA damage, and epigenetic changes, it results in the respiratory infections and increased risks of pneumonia, lifelong increased risk of COPD and lung cancer in children. Indoor air pollution. The sources are tobacco smoke, nitric oxide from gas cooking, and formaldehyde from particle board furniture, glues, and preservatives. Incense burning also adds to indoor air pollution. The exposure pathway and adverse health effects are the same as household air pollution. The common components are particulate matter, toxic gases, and volatile organic compounds. These are associated with an increased risk of allergic sensitization and risk and severity of childhood asthma. Exposure to air pollution outside the home. The sources are natural sources that contribute to the ambient air pollution. The six key pollutants in ambient air are lead, particulate matter, carbon monoxide, nitric oxide, sulfur dioxide, and ozone. The different sources are volcanic eruptions, industrial emissions, diesel engines, burning garbages, forest fires, traffic emissions, and burning crop stubble. These criteria pollutants, the six key pollutants, have national air quality standards set by legislation that define the allowable concentration in the ambient air. For example, by U.S. Protection Agency and by WHO. For different pollutants, there are different averaging time available, uh, which are the allowable exposure criteria. Traffic related air pollution, trap exposure. It increases the risk of severe respiratory tract infection. It lowers the lung function, reduces lung growth, causes wheezing illnesses in children, increases incident asthma and asthma exacerbations. It induces oxidative stress in humans, and it is also associated with an increase in school absence for respiratory illnesses. Finally, the impact of climate change on children's respiratory health. The source is air pollution, which increases the atmospheric carbon dioxide, which induces global warming and leads to climate change. There is a marked deterioration in air quality because of the increased particulate matter, surface level ozone, changed relative humidity, and air stagnation. It is linked to many health problems through increased temperature, decreased air quality, altered rainfall distribution, and ocean warming. The WHO predicts an additional 250,000 deaths per year between the year of 2030 and 2050 due to climate change. Air pollution and global warming leads to biodiversity loss, social disruption, impaired human health, impaired planetary health, and ecosystem destruction. The climate change impact by increased ambient temperature, which affects the urban health island effects, heat waves, increased temperature variability, and crop failure, which leads to heat stress, electrolyte disturbances, increased allergic sensitization, increased allergic rhinitis, and asthma exacerbations. It also leads to decreased air quality, which leads to higher particulate matter, increased surface level ozone, air stagnation, and rising carbon dioxide, which leads to decreased fetal growth and low birth weight, lower lung function, altered lung growth, increased bronchial responsiveness, increased incidental asthma and asthma exacerbation. It has also lead to increased hospitalization for respiratory tract infection and increased pulmonary function. The rising carbon dioxide has led to altered plant distribution and increased pollen production, which increases allergic rhinitis and asthma exacerbation incidences. Altered rainfall distribution has led to altered distribution of disease vectors, crop failure, water insecurity, and it has led to altered distribution of vector-borne diseases, increased susceptibility to respiratory infection, and ocean warming and sea levels have led to severe weather events, which has led to increased respiratory infection, asthma exacerbation, increased chemical exposure, and also adverse mental health outcomes. Climate change is an opportunity for physicians to act responsibly. The American College of Physicians urges that all physicians act and engage in environmentally sustainable practices and reduce carbon emissions and educate the public, their colleagues, and lawmakers about the human health risk of climate change, especially respiratory health. Take home messages. Children are more vulnerable to air pollution. Indoor air pollution is more prevalent in low and middle income countries. Incomplete combustion in homes and environment contributes significantly to air pollution. Early exposure to polluted air can lead to chronic respiratory diseases and other long-term health issues. There is an urgent need for global action for effective policies and intervention to reduce pollution and protect children's health. The message for the pediatricians and the parents taking care is that we need to stay informed regarding the air quality and the pollution counts. We need to limit the outdoor activities of the children during the poor conditions, maintain indoor air quality with proper ventilation, air purifiers, and indoor plants, and promote good hygiene and ensure children with respiratory issues have proper medication and care plan. Thank you.
Good
Dr.
evening, everyone.
Pratnya? Yeah.
Yes, ma'am, I'm here. Good evening, everyone. Thank you, Chitra ma'am, Neha ma'am, Mohanty sir, and Renu ma'am for the opportunity. And I can see here Narmada ma'am, who is my teacher. Are you there, ma'am?
Yeah, she's there and she's going to give her expert
Yes,
comments
ma'am.
after
She's my
you.
teacher, so I had a complex presenting here. Okay, so actually, this is very nice article, review article, which is about pollution. And nowadays, we are dealing more with allergies and asthma patients in our OPDs. Also, there is sudden surge. So why there is surge in post-COVID area? The children were in the COVID area. Children were more in the indoor. So in 2 years, there was decrease in allergies, but now after 2023, we are seeing directly surge in allergy and asthma patients. So now, in literature search, I found that New Delhi is the world's most polluted capital for third straight year. So, and as you can see here, so red mark states, these are most polluted. So Delhi and UP, Bihar, so these are most polluted states in India. And there is total loss of 36.8 billion US dollars, which is 1.36% of India's GDP. And Delhi has lost highest per capita economic loss. As we can see here, pollution and respiratory allergies go hand in hand. As the pollution increases, there is increase in incidence of allergic rhinitis as well as allergic asthma. So many people were asking me when we got this article. I circulated it through our residents also. They were asking what is PM 2.5, what is PM 10. So as you can see, this is hair strand. So what is normal diameter of hair strand is 50 to 70 micron. As we can see, the PM 2.5 is such a small, and PM 10 is also small. It is 1/10 of our hair strand diameter. So as you can imagine, these are such small particles we can't see, and we directly inhale these. As we can see in this slide, oropharyngeal region is 10 to 30 micron, that is PM10 are deposited here more commonly, and bronchi and bronchioles, which are smaller. So uh, PM 2.5, that is 2.5 micron diameter particles get deposited in the bronchioles and alveolar sacs also, which give rise to more bronchial asthma and other things. So now next question was why children are more vulnerable. So I found many points regarding this. So growing lungs are more sensitive to chemicals and pollutants present in the air. There is underdeveloped detoxification and antioxidant, as Dr. Prachi discussed here. What is oxidative stress? So whenever our defenses are overpowered by whatever oxidative stress we are dealing with, so it is undeveloped detoxification process in pediatric patients. The pediatrics are the children are physically active, so obviously outdoor activities are more as compared to adults. These children play more in the gardens and breathe relatively more air, as these are physically active. Children are mouth breather, as you have we are seeing in the OPDs. There are cases of adenoiditis, there are tonsillitis. So most of the times airway is hampered. They have recurrent rhinitis, because children are more mouth breathers. There is ineffective nasal filter capacity. What is nasal filter capacity? So we have a small fimbriae and hair inside, so which produce mucus, and these excrete whatever particles we are inhaling. So this is ineffective in children who are mouth breathers. So obviously whatever particles they are inhaling, these are directly going to lungs without filtration. And other thing is breathing zone is lower than adults, obviously, as height is less. And as Dr. Prachi discussed, there is more ozone in the air. But this ozone is not the protective one, which is in the stratosphere. This is ground level ozone, which is very hazardous to our health. Another question was, do air pollutants inhaled by mother cross placental barrier and enter into growing fetus? So there was one article who studied this, and they found 287 pollutants, chemicals, pesticides identified in the umbilical cord, which is very problematic. So most of the pollutants came from indoor sources. So as you can see in this pathway, as the child is in the womb, there is TH2 pathway which is prominent. You must have heard about this TH2 and TH1 pathway. So TH1 pathway is more protective against whatever infections we are getting, and TH2 pathway is allergic one. So as the child grows and goes into toddler age group, TH2 gets converted into TH1 with the thymus maturity. But what happens if the child is exposed in womb only? See, there is TH2 skewed responses. The child goes more into the allergic, that is atopic march, whatever we are learning about this. So child has more atopic tendency. So not only pollutants are harming the child once the child is already born, but in utero also this process starts. This is the slide mentioning the pollutant index after whatever we saw in 2005 and after 16 years, that is to 2021. As obviously, this is very obvious that after 16 years, party PM to 2.5 has markedly increased from 40 to 60%. And PM10 is increased from 40 to 100%. So that's why we are seeing surge in allergic rhinitis and bronchial asthma cases. So why there is sudden increase in allergy? Is it related only to pollutants? No, it is also related to increase in pollen grain productions. So there was one study where the scientists grew ragweed, which is known to cause hay fever in Western countries. So they grew ragweed in the chambers where they can control the atmospheric carbon dioxide levels. So as you can see, as the carbon dioxide levels increase, their pollen production by ragweed increase. So obviously there are increased chances of exposure to the allergens. There is one term called as diesel exhaust particle. Whatever this is really is traffic associated air pollution we saw in the article. So pollen becomes more allergic when these are grown in an environment because of diesel exhaust particle, and it increases allergen specific IgE levels by up to 50-fold. So to summarize, pollution affects allergies by increased pollen counts, as we saw in previous studies. There is increased pollen fragility. There is increase in pollen protein content. So these proteins are released in the environment, which cause atopic tendency in the child. Then there is increased pollen allergenicity by chemical modification of the DNA of the pollens. There is adjuvant effect by increased IgE levels, eosinophil levels, and there are neosensitization also seen, as we saw as the child is exposed in utero also. There can be direct injury to the mucous membrane, which is called as irritant effect, and direct bronchoconstrictor effect because of that. So child can have more exacerbations, and there is altered microbiota. So what should we do to combat this pollution? So as we saw in the article, they have said given emphasis on more emphasis on educating the pediatricians, educating all the pediatrician healthcare workers, and to educate our population. So why not start from the pediatric children who are school going? So we should teach them how to deal with pollution, then how not to produce more carbon. uh, so if the child is addressed, so we have a bright future ahead. So these are some plants, indoor plants given by NASA. I saw this beautiful slide somewhere. So these are very beneficial plants, which are some of these are known to absorb whatever pollutants are there, and some are oxygen purifying, whatever they say. So thank you for giving us an opportunity. We should be a part of solution and not a part of pollution. Thank you, everyone.
Thank you very much, Dr. Prachi and Dr. Pradnya. May I invite Dr. Narmada Ashok? And we are really fortunate to have you in Journal Journey. Dr. Narmada, please. Dr. Neha?
Dr. Pallavi ma'am, please unmute Dr. Nanuka.
Ma'am, given permission already.
Okay.
Thank you so much, ma'am. It's a great pleasure and my privilege to join in this meeting. I'm really fortunate to be with you.
Actually, you are not audible, ma'am.
Ma'am, we are not able to hear you properly.
Can you hear me now?
Little
Yes.
louder.
Can you hear me now?
Yeah.
Can
Little
you?
louder. Yeah.
Yeah. Okay. Yeah. Thank you so much for allowing me to join with you here. I'm really honored. Hello, are you able to hear me?
Yes,
Yeah.
ma'am.
Yes, ma'am.
Thank you. And both the presentations were very, very good and very comprehensive about the air pollution, especially the indoor air pollution. So you've spoken very And the good part is you also gave the solution for it to having indoor plants.
Ma'am, actually, we are not able to hear you.
Yeah, that's what I'm also seeing. I don't know what's the problem. Can we hear now?
No, not that
Voice is
clear.
little low, ma'am. You can increase voice of your device, whatever you are using.
Yeah, I will try to increase. Yeah, now?
Little better, but not
Better.
completely.
Okay. Now?
Yeah.
Yes,
Okay.
that's it.
Yeah, right. No, I was just telling that both your presentations were very nice. Especially you ended with a positive note, telling how as a pediatrician, how we can do to decrease the air pollution and talking about the indoor plants we can have. So that is a really nice thing. So the one thing is, I did my PhD on asthma and allergic rhinitis, and one of the commonest reason for the polymorphisms, genetic polymorphisms itself, is due to air pollution inside the home. And while we are talking about biomass fuels and smoking, the more problem is because of the grandparents also staying and co-inhabiting, where in my study 69 percentage the grandparents were the main reasons, because the mothers and father used to leave the children at home and they never understood that this was a problem. And quite often, when we are talking only about asthma and allergic rhinitis, we also need to stress on the points of allergic otitis media, which is a very, very big problem in children. Now, otitis media, when it is associated with smoking and air pollution, it creates a biofilm inside the ear, which is very difficult to treat. And it is painless. So parents do not come to us and tell the child had an otitis media and all this. So we tend to see the children at 10 years when they come with either school, the language problems or the school poor performance, and then we evaluate, we find them to have the chronic otitis media, which has already become glue ear. So it's not only the direct effect which we are having, we are also having many of the indirect effects for the same. So the main thing is we have to increase the awareness, and this is a very good way that we have all started talking about the same. And that's the biggest thing we are doing now. And we'll have to spread this message to the teachers and the school students also about the same. And one more thing we can do is reduce, reuse, and recycle. Whenever we change our products or any of this thing, we have to be very responsible in that also. When we change a mobile, be responsible, because one of the other things you beautifully spoke about the climatic condition. The other thing is the whenever we are changing the mobile, so much of heavy metals is especially gold, titanium is lost, and this is a mine from the mines where only children are employed in the labor. And even in when this mobiles are going into the recycling also, children are actually the street children who are collecting the waste. They are more involved in this environmental issues. They have a lot, because we discard the plastics, we discard the mobiles which are burnt, and the children working in the street hawkers, most of them are 10 to 12 years old children, which they are mostly involved in that. So we need to be very responsible also while we are changing our mobiles, changing our new products. Try to use the public transport system wherever it is possible. That is the way I think we should take it on, and see that even street childrens, we do not talk about it, but they are the most vulnerable. Somehow these are the people who are getting exposed also more. They don't use it, but they are involved in the industry more. So we'll have to think about the same. And as we all know, the environmental climatic change, the main problem in Wayanad, which is like they're saying official figures are 200, but it has touched more than 1,000. It is only because of the warm climatic condition which was created in the Arabian Sea that led on to the unseasonal rainfall. So that's really an eye opener, where we also lost a doctor family from Orissa. So it's hitting us very hard and very close to us. So as you all said, let's be responsible. We should be a part of the solution and not be the problem creators. Thank you so much again.
Yeah, thank you
Thank you,
very much,
Narmada
Ashok,
ma'am.
Narmada Ashok ma'am. It was very nice, and it is a strong message to all 165 people who are attending, that be the part of change. And one of the important message was if there is a hearing issue in the school, we have to make aware the teachers about the glue ear and the hearing problem, and then we have to investigate as well. Now, thank you again, Dr. Narmada. We move
Thank you,
on to our second presenter, Dr. Simra Sheikh is going to present about sudden SIDS, sudden infant death syndrome.
Thank you, ma'am. And because I have the IAP vaccinology course, I will just take leave, madam, now.
Thank you very much. Thanks for joining.
Thank you, ma'am.
Yeah. Dr. Simra, please.
Yes.
Yeah.
Should I share my screen?
Yes, please. Yes, please. Please start.
Yes. Good evening to all our esteemed faculty today. Journal for today is Systematic Approach to Evaluate Sudden Unexplained Death in Children from the Journal of Pediatrics with an impact factor of 4.41 by Annalette Maretta, published in 2023. Sudden unexplained death in children is one of the top causes of death in children. And when death is unexpected, families are overwhelmed with trauma, shock, and grief. The death investigation system in our country is variable, facing challenges like lack of resources and lack of standardization for the investigation of this death. Consequently, pediatricians may have difficulty providing appropriate guidance to families in the aftermath of these deaths. Therefore, we have taken this study for today to encourage the development of a protocol for evaluating sudden infant death and for improvement in counseling of parents regarding SIDS. Emphasis is also to be given on the preventable causes of SIDS to reduce infant mortality rates in India, which currently is 26.6 per thousand live births of 2023. Incidence of SIDS is 38.4 deaths per 1 lakh live births. Objective of this study is to provide cause and insights into sudden child death via the post-mortem evaluation of sudden unexplained death in youth procedure. This study was carried out in Netherlands. Cases were taken from 2016 to 2021. A total of 214 cases were included if parents consented to at least one element of the procedure. Age group was 0 to 18 years. Perinatal deaths were excluded as stillbirths and neonatal deaths were included in the perinatal audit register. Coming to the Pesuti procedure. It was founded by the Dutch Ministry of Health, and if maltreatment suspicion arose, the procedure was halted and the case was sent to the forensic medical examiner. The following points are included in the study. Postmortem physical examination was done by the forensics department and pediatrician. Medical history was taken by the pediatrician, which included previous illnesses, recent symptoms, circumstances leading to death, and resuscitation attempts. Examination of the location at which the child became critically ill or died by the forensics department. Biochemical analysis included blood, CSF, urine, and sputum examination within 2 hours of postmortem. Microbiological analysis included culture of blood, CSF, urine, sputum, and PCR was also performed on sputum samples. Collection of additional materials such as feces, hair sample was taken for toxicological, genetic, and metabolic workup. Collection of additional materials was also taken. Radiological examination such as X-ray, CT scan, and MRI was done for children of less than 4 years if child abuse was suspected. Autopsy by a child pathologist was done and tissue samples were sent for further analysis. Collection of any other additional information was also taken. The definitions included in this study include SIDS, that is sudden infant death syndrome. For children less than 1 year, if a sudden unexpected death occurred with onset of the fetal episode occurring during sleep, which remains unexpected after thorough investigation, including autopsy, history, and circumstances of the death. Explained death was defined if the postmortem findings collaborated with the history and autopsy. Plausible death if postmortem findings did not collaborate with the history or autopsy. Unexplained deaths if absence of history and postmortem findings related to the lethal condition. A total of 214 cases were taken, out of which 212 cases consent was obtained. Most children had collapsed in their home setting, that was 94%. Median age was 11 months and 56% cases were males. 33% cases had history of comorbidities. In 28%, professional care was sought before child had become critically ill. The Pesudi procedure resulted in explained cause of death in 58% children, plausible death in 13%, and unexplained death in 29%. The most common cause of death was infectious disease that was located to a specific organ, for example, cardiovascular, respiratory, or GIT. The second most common cause was non-infectious cardiac causes. Modifiable factors were found in 24% cases of non-SIDS cases. Substandard professional care was seen as a modifiable factor in 65% cases. Alarming symptoms such as difficulty breathing, neonatal fever, bluish discoloration of skin was overlooked by professionals. Other included insufficient instructions to parents, treatment failure, equipment failure, and leaving a sick child unsupervised, not recognizing alarming symptoms by caregivers. The maltreatment was suspected in 6 cases. Here we can see the cause of death was most commonly infectious in 76% of explained deaths and 12% of plausible deaths. Non-infectious was present in 47% of explained deaths and 15 cases of plausible deaths. The performed diagnostics, most commonly microbiological evaluation was done, 196 cases total. Autopsy total was done in 131 cases, and least common was endocrinal test done in 41 cases. The study adds to our knowledge the procedures useful for successfully identifying sudden infant death syndrome in children. The common causes of SIDS, which we have seen, is infectious diseases. The identification of modifiable risk factors in SIDS and recognizing inflammatory, immunological, metabolic, pulmonary diseases aggravated by a harmless infection. The limitations of our study include that no records were available to estimate the number of cases suitable for the Pesudi procedure, not investigated due to consent. There was difficulty in interpretation of the post-mortem results amid decomposition processes. And the toxicological, metabolic, and genetic evaluation was done less due to consent problems. Further scope of our study adds elaboration of the hidden biological vulnerability of the child for SIDS, which includes diseases like ion channelopathies, cardiac conduction defects, brainstem abnormalities, epilepsy, etc. Protective measures to be taken to prevent SIDS includes avoidance of co-sleeping, prone position, head coverings, and soft bedding for children. Relation of maternal smoking to SIDS and further causes of infectious diseases leading to death of the child. American Academy of Pediatrics had published their guidelines in 2016, which says a safe sleeping environment for the child, avoidance of smoke, alcohol, and illicit drugs by parents. Pacifier can be provided at nap time and at bedtime. Immunization should be done for all children. Supervised awake tummy time daily and reduce the risk for gastroesophageal reflux disease.
Yeah, please stop sharing. Thank you very much, Dr. Simra. May I invite expert Dr. Lalit Une sir for his comments.
Good evening, everyone. This is beautiful topic selected from study from original article from the Netherlands, and they have evaluated systemic approach in evaluating sudden unexplained death in children from birth to the 18 years of the age. Next, please. Every unexplained death is a tragedy with impact on family, community, and health practitioner involved. Evaluation may provide us understanding cause of death and opportunity to identify a potential modifiable risk factor. This is very important. So if we see, so there are important causes of sudden infant death syndrome. So these are, some are intrinsic factors, some are extrinsic factor, and some factor of related to critical developmental period. Some factor that is an intrinsic factor, genetic susceptibility, smoking, prematurity, alcohol, and drug use, among some other. And some baby who are especially infants and less than 6 months of the age group, they have critical developmental period. They are more genetic potential for SIDS. But focus is mainly on extrinsic factors which are modifiable and we can prevent that. So these factors are sleep position, soft bedding, over bundling, overheating, bed sharing, and upper respiratory tract infections. So these are the factors we can work on and we can improve, and that can be a preventable cause of a death, which is also shown in many studies. Next, please. So what are the evaluation method they utilize globally everywhere? So the commonest method evaluated done was CDR, that is child death review, which was practiced in UK and other countries and many other countries. So it was a multidisciplinary approach. They viewed and evaluated each and every death of a child death. In UK, it is surprising that modifiable factors identified in more than 75% of the cases. So how this study helped? So this outcome resulted in new public health recommendations. They are very much helpful. Then safe sleep campaigns followed after this recommendation, and better collaboration between the health services for improvement and better health services. So main motive was no child maltreatment death should remain undetected and should be reported, like child abuse, suicide, homicide, or any factor that is being operated. So in this Netherlands study, pseudo procedure, what they did, it's valuable and effective for determining unexplained and sudden death in children's. So the information will be useful, especially for grieving parents and involved healthcare professional. Sometimes what happens, sudden death is there, and healthcare worker, they are not able to explain. They should know that there are so many different causes they can be operating. So they should know so that they will be able to explain to the relative in a better manner. What is Indian scenario? The basic problem is we don't have any data or studies regarding sudden unexplained death. So we need a multi-centric study and a data so that different protocol can be formed. So need for a protocol for sudden unexplained death that should be suitable and cost-effective assessment method to be developed for an Indian scenario. Early identification of a modifiable factors for a better healthcare that can be planned. Healthcare provider should be aware of causes of sudden unexplained death in children below 18 years of the age group. Identification of a moderate to severe illness by danger signs and signals. So it has been noted in the previous studies, around 70% of the cases, the factors were modifiable. So, and out of that, most of the children had some infective illnesses. So if we identify the illnesses early, so this factor is modifiable, and so many of the death can be prevented early. Thank you so much.
Thank you, sir. Beautifully explained. And today we are blessed to have MMC observer, Dr. Ramakant Patil, sir. Sir, please give your valuable comments on both the articles.
Thank you, Chitra madam.
Thank
It
you,
was
sir.
wonderful to listen to young academicians and ably commented by both the experts and even Dr. Narmada. And I really appreciate Raigad IAP and Maha IAP, Chitra Madam, Niven Mohanty sir, for perpetuating episodes of Journal Journey and different topics. And SIDS is a really difficult problem. And many times it becomes very difficult, as Unesar has said. It is a bereavement and it is a shock and for everybody, the pediatrician, hospital, and to the parents. And most important, what he has said, that the routine examination, proper explanation to the new mother, her counseling, and some positions like supine position sleeping. If tummy time is to be given, it should be always under direct observation. These things are to be there, keenly observed, and it is very important to go long way. Fortunately, in our country, rooming in is there. Baby is not made to sleep in some other room. Baby is always sleeping with mother, and this rooming in, unfortunately, it is not unknown in our country, but it is definitely less compared to developed country. And probably these are the reason that baby is sleeping with mother, rooming in is there. And we do not advise prone positioning or lateral positioning, supine positioning only. And only in cases of GERD, severe GERD, not only GER, we should advise tummy time. And about environment, that we all know that it is touching all the systems of not only child health but health as such. And as ably put by Dr. Prachi, that why it is important, because children, for their small size per kg, uh, ingestion of all toxins through orally or through inhalation or skin surface and everywhere. So they are having more problem. And as Dr. Narmada has said, that children are exposed to these mining and environmentally very hazardous things. So it is responsibility of the pediatrician to make all aware about environment health. And very important is e-waste and not different environment problem, and that has to be taken care of. Wonderful topics. I congratulate Raigad IIP, Maha IIP once again. Thank you, and congratulate both those presenters and experts.
Thank you so much,
Thank you,
sir.
sir.
And it was your backing also when you were Maha IIP president, and we could continue this journal journey this 4th year also. Thank you so much, sir. And it's a time for question answers now. Can we get some question answer, Pallavi ma'am, from chat box? Any questions you could see in the chat box or YouTube?
No, ma'am. No, not on YouTube.
Okay. I think everybody has understood everything. That might be the reason that there are no questions here. Our mentor, Dr. Nimen Mohanty sir, is requested to tell about the selection of articles which we are doing for last 3 to 4 years. Mohanty sir.
Sir, unmute.
So kindly unmute yourself.
Yes, sir.
Unmute, sir. Please unmute.
Sir, kindly unmute.
Sorry, thank you. I am rather fortunate to be part of the journal journey. It educates us also, and by forces us to go to library at least 3-4 days in a month and search for the appropriate articles. Today's articles were chosen with a target that it should reach sensitize our pediatricians. Particularly the allergic march, it is there, but the pollution, which is the main problem worldwide, people are making hue and cry, but nothing is actually happening. This particularly the big cities are vulnerable. And so many things are so common now, she has already pointed out. I'm very happy they have, it's so close to their heart. They have gone tidbits of the details of the articles, and that is why there is no question. Probably people were really, the audience were taken along with them. That's a good sign. About the postmortem examination of the pediatric patients, what we normally see that they do not normally agree. But those who are located or posted in the academic institutions, if you convince them, they will agree. And we can, by multi-centric studies, we can pull data for the Indian data. What is happening to us? We should know. That is very important. And the misunderstanding between the parents and the doctors or the healthcare staff after death, that will also go lessen to a great extent. And I'll also suggest Dr. Pradnya, she is a qualified pulmonologist. See, these pollens, you can study in our areas. What is the pollens common, in which season they are common? And that season, you can, if you can study those pollens in the umbilical cord blood, and once the this is identified, same pollen in these children, once they're born, in the later part of their life, you can give a challenge and see whether they are reacting to it or not, and the IgE can be estimated. Some studies should be done. Why only the journal club is not enough? We are sensitizing the general pediatricians posted or working nook and corner of our country. It's all right, but simultaneously small little studies which is possible, feasible in our own clinics or in own hospital should be thought of. Thank you.
Thank you, sir. Dr. Jay Bhandarkar, our star member of Raigad IIP, is going to ask some questions.
Yes.
Dr. Jay, your comments, please.
Yeah. First, is very, I think important subjects are discussed now. Why these allergens other than need to be discussed? Because I think where they're treated like a infection. So rather is you are properly diagnosing allergies, you are treating like any patient with some respiratory other symptoms, even GI symptoms. Many times they are the toxin mediated or maybe some allergic to the food, and we give them to the antibiotics, and itself is increasing the antibiotic resistance. As you go Google it or other thing, go for the literature, you see that hardly any new antibiotics has been reinvented or discovered in last 5-10 years. Other just changing chemical structure by already existing antibiotics. So they are very important. Another thing about the SIDSS is very fearful for the parents itself, and it's even for the doctors also. Sometimes very difficult to explain to the patient about it. And yes, when you are learning it, the government setup, yes, we insist on the all patient go for the autopsy. Yes, I was registered in the Solapur civil, and a lot of cases, and each and every day I used to advise autopsy, and as such in the government hospital you can insist and you can make it compulsory, because within 24 is a medical legal case like that. Even I have done many partial autopsies. Yes, upper lobe pneumonia was there. Go for partial autopsy, confirm it due to it is a partial autopsy. And on one of the cases I remember there was a sudden death. Childhood illness doesn't get any clue to that, and that patient happened to be renal tuberculosis. So ultimately, it is I think you should get the diagnosis. Another case I remember is the professor of surgery, and that his child was brought dead, and we done the autopsy. That was a migraine infection. There was an aberrant coronary artery. So you get multiple, you can thought of the causes about that, and definitely, so please go to the history and to the deeper. As Ramakan Patil sir said, we are less in India because we kids is always with the mother. Even in our setup, up to आपका kid अगर 50 साल का हुआ तो भी mother के साथ में रहता है. There's our Indian, and that actually helpful for the kid, because ultimately the monitoring is important, because I always said mother is the first caretaker, and her response to the any disease, I during rounds I always see the mother face. So she is laughing, then I understand the child is better. As simple it is. So, and another thing, I was saying, yes, there's a silver lining to the cloud. Every house has the pulse ox, right? Even for that beautiful small pulse ox, even the mother can check in the hospital and her home, and they are always aware of the pulse oximetry. And there's another tool is added into the hand, not in the hands of the ICU in the hospitals, rather in the mother and family also. So thank you very much. And all learner, all audience, they should understand that I was the first presenter of this journey journal. I was the first thought given by me during 4 years back. And thanks, yes, I was still attending between, but great thanks to Chitra Kulkarni madam, our mentor Mohanty sirs, because both are these two people are continuing this journeys continue due to them. Yes, I attended in between. But it was a great, and is another, I can think the feather in the cap of the IP history. तो मेरे पे सीवी में आ सकता है like that कि that journey is one of the longest of the academic activity going on in IP history. So thank you very much to both of them. Mohanty sir called me 6 months back. जय जर्नी कंटिन्यू करना है या बंद करना है सर? बंद मत करो. जब तक आपको जमता है तब तक करो. Then hand over baton. I will suggest कि you find some other genuinely interested person, and rather we can give same responsibility to some rather searching for the presenter and their mentor and expert. Rather, I will suggest to give this responsibility to some other academically interested person like a Menas Sheikh. He's very much interested in like a HOD of the Lilavati Hospital, interested in the academics. Give to him the responsibility कि आपको presenter choose करना है, आपको topic choose करना है, so that you will relieve the burden as well as any superstar भी रहता है तो people want change. Salman Khan, Amir Khan, Shah Rukh Khan, and some other Khans are required because people want to see other people also. But
Yeah.
continue with the same journey. And thanks again, all
Understood. Yeah.
yes. Thank you very much for giving the opportunity to
Thank you.
talk in this journey journal. Thank you.
Your suggestions we will keep in mind, Dr. Jay, and thank you very much for giving this idea of journal journey to Raigad IIP. Similarly, the next session on 1st of September will be there, and few of them might be attending this journal journey episode. May I invite Dr. Shantanu Deb sir, Dr. Anamika, Dr. Himesh, and Dr. Pramod Ambatkar sir. Whosoever is present, please give your valuable opinion about this journal journey episode.
Hello.
Yes.
Yep, I'm Himesh Burman. So it was a pleasure listening to all the presenters and the way things were discussed. So I really want to congratulate the presenters and the experts. From my side, just one small comment on this. There was some discussion on absence of pathological autopsy data in Indian setting and how consent doesn't come through. So one technique that has been used is a minimally invasive tissue technique. So where actually one of the concern that comes is the disfiguration of the body that parents because of which they concerned. So then biopsies can be taken through small punctures from multiple wound, and then even microbiological and other tests also can be done. So that can improve our our diagnostics in these cases. That's all from my side.
Very nice. Thank you very much. We are grateful for you. I hope Dr. Hemant Gangolia sir, our Maha-IP past president, will give some guidelines about the functioning of this journal journey. Sir, are you there?
No, ma'am. Hemant sir is not there.
Dr. Jay, will you give vote of thanks from Raigad IIP?
First, it's a vote of thanks to both of you. First, Mohanty sir and Dr. Chitra Kulkarni for the continue this journey, almost 4 years. And all presenters and mentors, and of course, all the audience. Thank you very much for joining this today's session. I will not take the name details, but everybody involved in this process, please join. Though you are a presenter here, please join as the audience also through next journey journal, give your reports. Thank you very much. And I see that very young presenters are very, very important. I never miss journal club during my learning at undergraduate or postgraduate in the Vivek Medical College, Sholapur. I love that. The timing was 4 o'clock to 5 o'clock. भरपूर जेवल्यानंतर शांत झोपायची वेळ होती तरी मी ते अटेंड करायचो कारण आय लर्न अ लॉट ड्युरिंग दॅट बिकॉज इट इज व्हाय इट इज आय admire it or why it is love it. Very simple. It gives lot of topic for the discussion. And our Mohanty sir said कि कैसा प्रेजेंट करना चाहिए और कैसा प्रेजेंट नहीं करना चाहिए जर्नी जन में समझता है तो लेट हिम समटाइम्स प्रेजेंट सम ऑड टॉपिक ऑड फिगर्स maybe wrong data so that we can discuss that what to dig out the information. So कैसा होना चाहिए लेकिन कैसा नहीं होना चाहिए, that is also very important. So thank you very much. I think Minas sir want to say something. Minas sir.
Yeah, good evening. Though I tried to restrain myself, but I could not for the simple reason, though I joined late. But I must say one thing. The way I was in second presentation of the seats with Timra and Dr. Our Lalit sir, I must say the way it has been presented exceptionally well. The way the maturity wise, the content wise, the expression wise, it's no lesser than I was lucky to work at PGI Chandigarh and Gangaram and all. It's like that. It's heartening to see that level has been achieved. So congratulations to first their mentor, because the good student, of course, they work hard, but without teacher, they're not a good student. So I must compliment Dr. Lalit and his entire team for making out such a good student from their kitty. That's number one. And number two, of course, the Chitra madam, the Mohanty sir and the team Raigad. Because you must see, I tried to make it, this is one program which I always try to join in. So, and you learn a lot. One important thing is that without journal, we are nowhere. We are nowhere. We have to have journal. So this is one program which is going excellent. Lot of good inputs, lot of good learning, lot of hard work. Congratulations from our side. We'll always be there. Good night. Thanks a lot.
Thank you, sir. Thank you for the.
Thank you very much, sir. Thank you very much. Thanks for the good words and your interest in journal journey, Raigad IIP and Maha IIP. Thank you very much. We also thank our great help, Dr. Neha Singh, Dr. Vishal Raut, and the entire team, along with Pallavi Dharmadikari ma'am, for continuation of this project for last 3 years. This is the 4th year. Thank you very much. Pallavi ma'am.